to help you get the most out of today's session. You have joined the presentation listening using your computer's speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's panelists by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will address questions throughout today's discussion. I would now like to introduce Michael Carroll.
Good morning and welcome to Market Insights Live. My name is Michael Carroll and I'm the Chief Marketing Officer at TripleTree. Today's session is titled It Takes a Village, Evolving Models of Community-Based Care. We're fortunate to have a great group of panelists who are changing healthcare and how it's delivered in a community-based setting. A reminder that the views and opinions expressed in today's conversation are those of our participants and do not necessarily reflect the opinion or official policy of TripleTree and its affiliates. To begin today's conversation, I'd like to introduce my colleague, Nate Shivers. Nate, take it away.
Thanks, Michael. Good morning, everyone. I'm Nate Shivers. I'm a director with TripleTree, focused on M&A advisory services across the health plan, consumer, post-acute, and alternative site care landscapes. I want to reiterate what Michael said. Thanks to everyone for being with us this morning for what is sure to be a thoughtful discussion with industry leaders and innovators across the topic of community-based care. Before I turn it over to our panel for today's discussion, I want to spend a few minutes introducing the foundational aspects of today's topic and highlighting a few key areas of focus that you will hear woven throughout this morning's discussion in terms of themes, tailwinds, and overall activity driving the innovation that we're going to hear about today. If you could go ahead and turn to page 1. What you'll see outlined here is really at its core, as we think about the macro trends that are driving the community-based care innovation that we've seen in the marketplace and what our panelists are bringing to the community, what are those 4 pillars that you're going to hear really driving the need for change in the way that care is delivered? First and foremost, consumers are demanding more from their healthcare system. They're demanding convenience, they're demanding better access to care, they're demanding the comfort of their own homes, and they're demanding elements of other industries that they are used to as they think about the way that they shop, the way that they engage with other industries, and they want to bring that convenience to healthcare. If COVID has shown us anything in this pandemic that we've gone through, it's that we have a healthcare system and a consumer who are willing, able, and ready to engage with the healthcare system in a new way. And the rise of technology and other remote models of care have continued to grow throughout this pandemic, and we believe will be at the forefront of how care continues to evolve based on consumer demand. At the same time, the demographic trends that we're seeing in the marketplace are driving a need for innovation. By 2060, the population of seniors 65 plus will double and will require increased amounts of in-home care and work that they will need in order to continue to age and live a healthy lifestyle. And at the same time, the number of chronic conditions that we're seeing in the marketplace is continuing to rise. These demographic shifts require a different level of care, and they require a insight and a touch from the healthcare system that does not exist simply within the 4 walls of the hospital. Now, while it's obviously a need for the consumers, it's also incredibly cost effective for our entire system to deliver care in innovative ways within the home and in the community. The average cost of providing the same level of acuity care in the home is over 32% cheaper than it is in an acute setting or a more traditional hospital setting. And because of that, constituents across the healthcare landscape, from health plans, providers, and others, are all driving to figure out what levels of care they can better provide within the confines of the community and the home. And lastly, but perhaps most importantly, the system and the healthcare marketplace have continued to understand and develop an acute focus on the fact that it is much more than the clinical elements of how care is delivered that impact the overall outcomes of their patients. In fact, studies suggest that over 80 to 90% of a person's overall health outcomes are driven by non-clinical factors and what we'll refer to broadly throughout the discussion today as the social determinants of health. What type of transportation needs does somebody have? What type of nutrition is a patient getting? Do they have access to their medications or to the care that they need? All of those elements play into the overall outcomes that a patient is going to see, and the ability to weave care into the community and into the home that can address both these social determinants as well as clinical aspects of care is absolutely critical to delivering an appropriate outcome. Flip to the next page. Just to spend a minute on this page, what we've outlined here is just highlighting the broad focus of all of the things that can be accomplished within the community as you think about care delivery. Obviously, the ability to deliver actual hands-on care is critical, but in addition to the care that you can deliver, there's also incredible insights that can be gained from being within the community and within a member's home. For example, identifying opportunities to flag risks and gaps within a patient's care that may not show up in a clinical chart, but could be apparent things that could easily drive admissions to the hospital, emergent care, or other needs that could be avoided if there were some level of intervention. The ability to identify those gaps and push that information into the appropriate settings helps the healthcare system better coordinate care, better stratify risk, and ultimately better provide high quality care to a patient population with significant need. That combination of the ability to gain insights as well as deliver a higher quality, lower cost care all create a compelling reason why the home and the community are such a critical element to the way that our healthcare system delivers care. So without further ado, I would like to introduce my colleague Dave Brownlee, who will be moderating our panel this morning. As a reminder, I will be revisiting the discussion here throughout the morning and monitoring questions from our audience. So if you have a question that you would like to raise for our panel, please feel free to use your control panel on the right and submit that. Dave, I'll turn it over to you.
Thanks, Nate, and welcome to our panel discussion on community-based care. We're joined here today by three industry leaders and pillars of their own communities who we're excited to have with us here today. I'll start with a quick round of introductions. First, we have Jason Rose, the CEO of Adhere Health, a leading healthcare technology company focused on medication adherence. Jason has had a long career in healthcare technology, most recently prior to Adhere, serving as a senior executive at Inovalon. Since coming to the company in 2018, Adhere has shifted its focus toward a SaaS technology offering that helps its clients target and engage consumers who are not adherent to their medications. So Jason, thanks for joining us here today.
Good morning.
Next up, we've got Nathan Goldstein, who serves as the Chief Strategy Officer of Signify Health. Nathan has a long history in government-sponsored programs and publicly financed healthcare. He's worn many hats at Signify and its predecessor companies, spanning sales, strategy, corporate development, and associated functions. For those who are not familiar with Signify Health, the company manages one of the largest networks of mobile clinicians to help really transform how healthcare is paid for and delivered in the home and in the community. And finally, we have Dr. Mark Prather, who is the CEO of Dispatch Health, a company whose mission is to create the most advanced and highest acuity in-home care model in the industry. Mark is our esteemed physician on the panel with over 20 years of experience as a board-certified emergency medicine specialist. He's also been involved in multiple medical industry startups, including iTriage, which was sold to Aetna, before founding Dispatch Health back in 2013. So again, thanks everyone for joining us here today.
Glad to be with you.
So Nathan, why don't we start with you on an important topic that was previewed a bit in the intro, and that is the significant impact of non-clinical factors that influence our overall health and well-being. Social determinants of health, generally speaking, you and I have talked about this idea that we all have social comorbidities in the same way that we all have medical comorbidities. How are you and Signify bringing this to the forefront in improving care for the populations you serve?
Yeah, thanks for the question, David, and thank you to Triple Tree for the opportunity to bring us together. Really honored to be in the panel with these esteemed gents. So yeah, I've got a long history in supporting health plans meet quality of care goals, and plans have had things like transportation benefits and supplemental benefits that address what we today put into that broad category of social determinants for a long time. But as you alluded to in the question, they've typically done so in an isolated manner. When dad doesn't get to his primary care appointment, it might be that he needs a transpo benefit. It might also be, as you alluded to, that he's uncomfortable leaving mom at home because she's beginning to show signs of early dementia. So what's going to get dad to the PCP? Is it the ride, or is it someone who can support mom while he's away for a couple of hours? Until you know that about the patient, you can't begin to address the root causes of whatever is standing between them and good health. Sometimes that's standing between them and a visit. Sometimes that's standing between them and healthy eating, however you define it. So the first step is to understand with empathy and with the willingness to embrace the same level of complexity we would on a clinical standpoint, on a social standpoint as well. The second step, though, is to be able to organize and galvanize the intervention efforts around those patients. At Signify, what we do is we use software to connect community-based organizations who, we have to note, have been serving these populations sometimes for a century or more in their home communities. We put them in a novel legal structure. And then, because many of these organizations have different laws governing the privacy of the data that they are entrusted with, you think of a domestic violence shelter, an addiction and treatment center, a food bank, a senior ride share, totally different privacy laws governing that data. We've got a privacy engine in our software that allows that data to move freely. What that means is that when you, as a client of one of these CBOs, enter any one CBO, every door is a front door, and your information can now move freely throughout the community. And we're now taking these communities that have our software as an operating system and tying them into our health plan and health system customers and connecting the clinical and the social spheres and allowing them to see holistically what's going on with patients, thereby creating a social longitudinal record that we pair with their clinical longitudinal record. So the basic strategy is the same. Just as we at Signify try to connect providers across sites of care to give somebody a smooth patient journey, we're now taking the same thing and applying it to social service agencies and private organizations, and then connecting those two strata with technology.
Right, and I think you guys just announced a partnership with Independence Blue Cross. We're bringing this to life a bit. Maybe just spend a minute just in that kind of real life example how that's coming together.
Sure, that's been one of the most invigorating and honestly inspiring things I've done in a number of years. IBC is, for anyone who doesn't know, deeply embedded into the fabric of Philadelphia. They've got a relatively small service area for a Blues plan. They are Philly and Philly is them. And they were a partner of our in-home services already. And we went to them with this model that that I just described at a high level. And I think what helped us come to a common understanding is, first of all, what we're providing is an operating system for their strategy. It's not our social strategy. We always begin with outcomes in mind. So IBC, what are you trying to solve? From that point, we then assembled a particular network. We were not trying to get every CBO, community-based organization in Philadelphia, onto the platform. We were trying to get those that would make the most impact, that were already seeing Independence members. Independence's case managers know who these organizations are. The discharge planners at Penn or Jefferson, the big health systems there, they know who these organizations are. So it's no mystery. But you have to then go to the organizations with empathy for their mission and earn their trust. As the founder of this business division likes to say, it moves at the speed of trust. I think you might have nicked that from Stephen Covey, but that's okay. And we get them bought in on how working together is going to help them further their mission and this is a public health term, collective impact. And the managed care entity in this case has to walk with modesty here, because these organizations, some of them are in Philly 125 years old. They've been doing this a long time. They know these communities. So you can't say, hey, we're the HMO and we're here to help. You've got to be a bit more respectful of their mission than that. And independents really understood that. So we are now using data we collect in our in-home program to further enrich analysis we do of their population to identify the comorbidities, the social comorbidities that these members have, and then use those to trigger referrals into the CBO network. And because they're on the platform, Independence has transparency into what's happening throughout the community, and they can see all the other engagement points they have to their members. That's a really important point. These CBOs as a collection might be seeing and serving these members 30 and 40 and 50 times a year. That's an enormous opportunity for a managed care plan.
Yep. Mark, one of the benefits to being in the home is that you're no longer limited to whatever information is contained in a traditional medical record. I'd be curious how Dispatch leverages non-clinical data in your home visits, and as a provider, how are you, incorporating social determinants into a member's care plan?
Yeah, our value is really predicated on our ability to provide care that substitutes for the emergency room, for hospitalizations, for skilled nursing facility stays in a lower cost setting with the same or better clinical efficacy and improved satisfaction. And one of the things that diminishes our medical cost savings is recidivism to a higher cost setting after treatment by dispatch. So we realized early on as we started the program, and frankly before the word social determinants of health was fashionable, that reduction in recidivism was really tied to addressing many of these social issues that were so visible to us in the home. It's hard to ignore when you're going to write your care plan and you say, please see your doctor in 2 days. The patient can't walk across the room, there's no vehicle, and there's no one to drive them, right? So you have to act and behave differently, and frankly, that may be part of the reason that in-home care has more clinical efficacy. But early on in our development, there weren't many options for our providers to assist with these issues. However, increasingly, there are more vendors and more mechanisms for reimbursement. In each of our markets, our providers have access to a database that we've just sort of created organically over time of partners that we then parse by sort of payer and ability to reimburse for each of our patients. And although not complete in every market and for every payer, we're increasingly able to help our patients with these issues. And in our more longitudinal models, like the hospital at home model, we call that advanced care, we actually receive a bundled payment. We become the payer, and it gives us great leeway to actually pay for all of these services and arrange them ourselves.
Great. And I want to come back to that point on bundled payments here in a second, but as you marry kind of that social data together with the clinical data, are you, or to what extent are you leveraging data from your health plan and your health system partners? Is there, what's the integration there look like?
Yeah, it's a bidirectional feed, and it's not with every partner, but in many instances, we receive a collection of retrospective data. That actually helps us because many of our patients are semi-emergent, and we have to stratify whether that's the appropriate patient for us. So having that retrospective data is incredibly valuable. We also have a technology platform that enables this care delivery, but there's also a robust database on the back end. So as all those providers are inputting their records, they're also doing social determinant screens that is structured data that we are then feeding back to our plan partners, their care management function, or our primary care partners. So bidirectionally, we're creating, I think, a more robust picture of those members.
Great. Jason, I always think of it here as sort of a technology first solution. Maybe talk about the link between social determinants of health, your technology platform, and ultimately how you leverage that technology to improve outcomes and influence behavior.
Yeah, Dave, and thanks again to you and Triple Tree for the opportunity to speak today. It's as the old adage is, it's not the genetic code, it's the zip code. And that is all about social determinants of health. About 2 years ago, CMS changed their guidelines to allow for health plans to use the social determinants of health benefits into the medical side of the budget. And that has transformed how health plans look at how to invest into these areas of overcoming these types of barriers of care. And it's really important to think of that in terms of, and I think both Mark and Nathan has touched on this, is it's like the Maslow hierarchy of needs of healthcare: food, water, shelter, health literacy, access, transportation. Those are really critically important in order to overcome those barriers so that you can actually improve quality, improve cost of care, improve value-based reimbursement. And the way Adhere takes a look at this is we take a very holistic view of the patient. So we're pulling in on a daily basis medical data, pharmacy data, eligibility data. We're pulling in HEDIS information. We're pulling in hospital discharge data, the health plan's benefit structure itself, the community resources that are available to that patient or that member that are available. And so when we actually are engaged with the consumer or our client clinician or their provider network, they're enriched with a guided workflow for that specific measure from a CRM perspective, holistically, customer relationship management. And then that guides to what are the most important things for this member today. So if we're talking about a Medicare Advantage D-SNP, dual SNP member, which is Medicare Medicaid dual, or a Medicaid member, you might find different types of social determinants of health issues for that particular member than you might find with a commercial member who has high risk, high cost, taking 15 drugs. So all those things need to be captured, and Mark used the word structured, I use discrete, but what are those specific data points that need to be captured, not in a free text case management tool, which most health plans use today, and not in an Excel database or Access database, actually in a CRM tool that discreetly captures what is the SDOH issues that are challenging this consumer to advance their quality of care. And then you're on this adherence journey in terms of how do we have this pathway. Most of the issues that we have with these types of consumers are not one phone call, one and done. And most organizations are really transactional in the way they would react versus a longitudinal process of building that adherence journey.
Yeah. You know, one of the potential question marks regarding social determinants generally has been around attribution and quantifiable value. We know it matters, but we can't put our finger exactly how much. I imagine you're able to point to some fairly specific ROI stats around quality and star ratings, but how do you talk to your clients about that?
Well, yeah, the way we look at it is we always consider this, and this is maybe a bit controversial, but our biggest competitor is actually our client. And so we need to constantly prove value from our technology. And when we use technology-enabled services, our clinical team of hundreds of people across the United States, we have to ensure that the client sees value in terms of what we can do. And so what we've done is we've transformed our internal tools and we've commercialized them to be available externally to our clients. And we have several examples of health plans across the country using these tools now. And so the value proposition is very straightforward, is ensuring that if it's a Medicare Advantage plan, we're looking at how much do we outrun the rest of the country in terms of the growing cut points. So that might be the plan is trending at a 2-star or a 3-star. We need to get them to a 4-star. And so 52% of a star ratings for CMS, 52% of the weighting is actually medication-related issues. And so those are the types of things that we focus on in terms of actual results. Each measure is different. So a Medicaid measure is different. The state of Washington will operate differently from a value proposition than a qualified health plan on the exchange, or a commercial plan that's reducing cost of care and has no government-based reimbursement. So each of these areas have different quantifiable values in terms of the value proposition.
Yep. So I think we've all established that social determinants are an important component of a longitudinal member record, particularly in a value-based care construct. As we think about value-based care more broadly, another necessary prerequisite, at least in my mind, is the ability to provide the the right level of care at the right time across care settings. Mark, I imagine Dispatch was founded with this very thesis in mind, providing the appropriate care in a low cost setting, being the home. Can you talk about how your model has become an enabler for your health plan and your health systems partners in their ability to more effectively participate in value-based arrangements?
Absolutely. So, we spend $4 trillion on our healthcare system today, and about a third of that spend can be attributed to emergency room visits, hospitalizations, and post-acute stays. So we're really driving value by recreating a significant portion of that care delivery in this lower cost setting. And I think you'll hear this theme, the home, in a manner that produces improved outcomes and improved satisfaction. So on average, our ER diversion model saves our partners between $1,000 and $1,500 per intervention. And the early results of our home hospitalization model suggest savings in the $5,000 to $7,000 range. So we really position ourselves as the Part A savings solution for capitated partners. We don't manage lives longitudinally. We're really designed to align closely with those longitudinal care providers and align in a way that's different than a typical facility-based acute care model does. We commit to care plan integration. We talked earlier, sort of the transfer of data that describes the social situation, frankly, in a manner that is different than they typically see, and additive to the information that most value-based care providers currently possess.
And how do you determine, or where do you draw the line in terms of what care should be provided in the home versus what is more appropriate for an institutional setting?
Yeah, so I'm lucky in that I spent almost 25 years managing, I think it was 64 ERs, 12 hospitals programs, and 6 post-acute facilities. So the medical evidence was something that I started with, and it goes back to my days at iTriage, where we knew that a large portion of the care in an emergency room could be treated elsewhere. And I think of an emergency room in thirds, where a third of the care should probably be there. Somebody needs an advanced procedure, admission, an advanced image. A third of the care, frankly, is an ambulatory sensitive condition that should be taken out by a lower acuity model like telemedicine. And then a third of it is really where dispatch lives, that sweet spot of, the patient with a COPD exacerbation, or a gastrostomy tube that fell out, or urinary retention. These are all things that almost always go to the emergency room, but almost always go home. And so there's an opportunity, if we increase the scope of care delivered in the home and do it safely, and we've been doing this since 2013 and hundreds of thousands of patients to date, that we could really lower the cost of care and take almost 60% of that emergency room and move it into the home. Similar sort of thought process around what can safely be hospitalized. That literature is mature. There are countries around the world that do this routinely. New Zealand, I think the Minister of Health came out a couple of years ago and said, we'll never build another hospital. And so those hospitals will ultimately be used for ICU admissions and surgeries. So it can be done. The economic incentives to admit people to the facility are great, right? The reimbursement is significant. So, a model like ours is fairly disruptive because it is a lower cost model that is pulling care out of the walls of those hospitals.
Yeah. And as you shift that higher acuity care into the home, the hospital at home model, from a technology perspective, how have you been able to replicate the various systems that have been built over the years to support institutional care?
Yeah, that's been the fun part. So part of my background also in business school was I became interested in queuing theory and logistics, and really, frankly, to apply to my own emergency rooms. But that background was very helpful as we thought about dispatch health. So all of a sudden, you have to move assets around, not just in relationship to distance and traffic, but you have to move them around in relationship to disease acuity. So we started with the on-demand ER model and really honed our skills over the course of almost 7 years And then in the last year and a half, we've methodically built our home hospitalization model, where that logistics dance that we do involves not just our clinicians, but now community providers. So that if the doctor orders twice a day nursing, physical therapy, DME, that all has to be orchestrated in a way that it arrives just like it would in the hospital. And so a lot of what we built in our technology is that sort of risk stratification, decision support, but also a very sophisticated logistics tool that does that. And then we use, a lot of vendors in terms of remote patient monitoring, PERS devices to augment the service.
Great. So Nathan, part of what we're solving for here in a value-based environment is not only how we deliver care, but also how we're paying for it. Signify has been on the front lines of bundled payments and episodes of care for some time, particularly through your acquisition of Remedy Partners. How do you see that opportunity for bundled payments and leveraging your platform to facilitate that kind of model?
Yeah, this is a really I've come to love the episode as a model for managing risk, because it does something I think that's really unique, which is it creates a, if you will, spontaneous, vertically integrated system around the needs of a patient with a really sharply defined focus to drive outcomes and care planning. Many people think of episodes as planned procedurally driven events, a knee replacement. And of course, those are subject to bundles in Medicare's BPCI program, where we're the largest convener, running about 50% of that program. And that program is largely a post-acute program, which again is how most folks think of episode-based payment. But as you get into the commercial world, you find that episodes are to be found in treatment for addiction, in high-risk maternity, pregnancy and delivery events, and in management of chronic conditions. And it is a way to, in our view, ask providers to do what they do best, which is not managing risk at a population level, but at managing patients on a patient level. So instead of saying to that hospital system, we want you to turn into an insurance company overnight and start thinking like actuaries in order to manage your value-based program, we're saying we want you to be collaborative with your downstream entities, work towards a target together, but everybody focus on doing what they do best. And we are at Signify the interstitial sort of layer. We are connecting all those dots. So we're never replacing the facility. We're not replacing dad's primary care physician. We are getting dad from that acute event, which does typically kick off an episode, even if it's not procedurally driven, and then managing him home as quickly as possible. That's our mission, is to transform the way that healthcare is paid for and delivered so people can enjoy more healthy, happy days at home. It's really simple. And the way we have our business organized, not to show you all my baby pictures here, but the way we organize the business is in managing someone home and then keeping them at home, as healthy as they can be. And what we've needed to bring into the system that wasn't there, and Mark's doing this as well, masterfully, is putting healthcare resources to places where they haven't traditionally been. Again, we're not trying to interfere what's going on inside the four walls of the clinic or the exam room or the OR. But we are trying to put healthcare resources where health happens, as opposed to where traditional treatment happens. And that, we feel, is a foundational point of view to value-based care. We really believe three things at Signify. We believe that consumers of healthcare want personalized services. Secondly, that the space beyond the office is generally unmanaged, and that's where health happens, to my earlier point. And that this shift towards value-based care is permanent. And if you were a naysayer on value-based care before, take a look at the money hose that the federal government has had to whip out to keep many of our community hospitals afloat during the pandemic as utilization plummeted. That, to me, to paraphrase Warren Buffett, that was the tide going out and seeing, everybody whose pants were down, or whatever that expression is. That just showed how fragile this recession-proof industry of healthcare actually is. And it's fragile because it's dependent not on getting paid to keep people healthy, but getting paid to treat people while they're sick. We've been saying that for as long as I've worked in this industry. Boy, did it just become blatantly obvious this year. So it's it for us is about finding these novel risk models. We internally call it our risk chassis, that we can, in the episode, inset into any other kind of risk chassis, and focus the resources around the needs of patients in their moment of greatest need, using skills of population health, using skills of segmentation, using actuarial sciences, all of that to drive putting resources where they're needed most. But then from a product and consumer and clinical experience standpoint, building everything around the needs of the patient.
Yeah. As we said in the intro, your organization manages one of the largest networks of mobile clinicians in the industry. Is maybe talk about how that asset can drive, improved performance around those episodes of care, having those clinicians in the community.
Yeah, so I mean, I'll start by saying that our episodes division has been at this for almost 10 years. There's a lot of experience in being the analytic and the financial chassis on which these bundles and episodes run, working with our 500 hospital partners, their 3,000 SNF and home health agency partners, and other sort of entities in that value stream. But until the last year, the company hadn't put its own clinical, social, behavioral resources to bear to make those episodes perform better. We were always providing data, insight, and decision support for those partners on next site of care decisions and things like that. So we've begun transition to home programs with some of our partners in the episodes business that do exactly what you said. It's partially about the mobile network of 9,000 doctors and nurse practitioners we have in 50 states. It's also about the experience we have in member engagement and through our social determinants work in meeting the behavioral and social issues that are often the drivers of readmissions, of adverse health events of all kinds. You don't always need an MD in the living room. In fact, most of the time you don't. What you need is a trained person with access to social and community resources often, who knows when to make an intervention with a member and get them the support they need. And sometimes that comes from us, sometimes that comes from a partner, sometimes it comes from a person like a PCP that the member's already familiar with. So, going back to the theme of this talk, it takes a village. The mobile network is one piece of the puzzle in terms of getting people repatriated to home quickly and safely, but the social and behavioral aspects just cannot be underestimated in terms of their impact on health outcomes once someone has been discharged safely from an acute setting.
Yeah. Jason, one topic of debate as it relates to value-based care has been the use of carve-in pharmacy services to drive a more integrated approach and coordinate care, across pharmacy and medical benefits. How are health plans thinking about this right now, and where does Adhere fit in that context?
Yeah, really important question. Not a stat that is used in I'd say the top issues within our healthcare issues of today, is that $500 billion every year is avoidable if we can improve medication adherence. That's 16% of the U.S. healthcare economy, $500 billion, if patients took their medications. And today, 50% of Americans don't. They don't take them by evidence-based guidelines. That could be adolescents, teenagers, adults, and geriatrics. They just simply don't take their medications. And that causes $500 billion a year. And that's not my study. That is the Annals of Pharmacotherapy 2016 study. And so it's with the aging baby boomers, it's probably well north of $500 billion at this point. And if you start there and you think about, well, how is, and I think Nathan mentioned this a moment ago, the government is behind this in a very big way. So the Medicare Advantage star ratings, as an example, is putting half of their $7 billion annual pool into medication-related issues, because half of the weighting is medication-related issues. But if you if you look into the private sector, into commercial self-insured employers and fully insured commercial players, then you look at things such as carbon pharmacy. And so the trend right now, and it's really important, is when the health plan has responsibility for the medical side of the benefits, well, what's the best way to reduce the costs? It's pharmacy. It's absolutely the pharmacy. And where is half of the pharmacy cost today? It's in specialty pharmacy. And where is that? That's actually in the medical data. So PBMs really aren't focusing on specialty pharmacy because it's not even a data stream they probably even receive. So if you think about where the costs are hidden, it's actually in the medical side to either A, get the patient adherent on the drug that they're not taking adherently, or maybe never even took at all. Looking at ICD-10 codes and identifying that there are not pharmacy associated, or at least not adherently with this diagnosis, is critically important. And so I grew up in the last 30 years, going through waves of different issues that really took healthcare from a homogenous point of view. Everyone remembers disease management and the Medicare health support debacle when a dozen or so very large organizations across the country failed in the experiment to take disease management to Medicare fee-for-service, and it was an absolute failure in 2009. And so those issues were mainly due to that cost reduction could be 20 years from now. We got someone that stopped smoking 20 years from now. If they happen to be still working for you, which is unlikely, maybe you avoided lung cancer. So what I'm talking about is actually in-year savings. This patient's not taking their medication. Because of the disease that they have, they're headed for problems. And identifying that in real time and then acting upon it from a clinician perspective and reaching out to consumers and their doctors, pointing these things out, also identifying other issues in specialty as well for cost reduction is really important, and that will absolutely move the dial. And I would say today, Dave, we're not seeing that as one of the most important aspects of the country.
Yep.
And I guess to answer your question, I'm sorry, where does Adhere Health fit in? So we've been doing this for 15 years. We've been working with the commercial side of the business, self-insured employers, commercial organizations for over 15 years. And so what we've done more recently in the last couple of years is we transitioned our tech so that the large employer organizations or the large health plans who are having their clients, our employers, are really pounding the fist at the table. I need your help. I need to reduce the rising costs of premiums. What are you going to do for me? And I think that the carbon pharmacy aspect is a wave that's occurring, but these plans, again, they don't have the tools to identify the issues and the priority and which consumers need to be reached out to and when, and which doctors need to be addressed as well, holistically at a panel level. And these are the types of things that we're seeing a very big trend in. We have a plan that's one of the largest plans in the country. It's half a dozen states, well north of 10 million members, who's implemented this technology system. And it is a mission critical aspect for any plan that's looking to reduce the premiums, which should be everybody.
Yep. I see my colleague Nate popped up. It looks like we might have a question from the audience here.
We do indeed. We've got a few questions, really all focused on a similar topic, and that is, if you think about, we talked about social determinants of health, one element not mentioned as acutely was the broader behavioral health impact, the concept of isolation, loneliness, how those can lead to depression, and what depression can do to the overall behavioral health of an individual and how that impacts their overall health. So the question is, can you speak a little bit to what your organizations are doing broadly to address the root cause of those behavioral health issues and how you're weaving behavioral health into the way that you're delivering care in the community?
I mean, I'll jump in with it if it's open. Sure. It's a great question. And I'll say, I think that we are really at the beginnings of our learnings on how to do this in a value-based and in a scaled way. Behavioral health issues, first of all, it's a broad category. Addressing the issue of senior isolation and loneliness is one of the most impactful things that we can do. And it's not easy. I'm just thinking of my own family and the challenges we've had in staying connected to everybody, particularly through the pandemic period. And again, this last year, I think, has shown with, I would say, an element of tragedy, just how disconnected we've become and what a empathy recession we're in as a culture. And I'm a big believer that the universe restores balance. And I think as we're seeing the green shoots of response to the way COVID has scrambled society, we're seeing greater attention to the issues. It begins with an empathetic view of the patient that comes from sitting knee to knee, if you can, wearing PPE, as we do now in the home, and engaging with them in a conversation that isn't a 6-minute drive-by in a clinic, not to knock any PCP doing the best they can with the patient volumes they have. But that is just not the right setting to get disclosures about behavioral challenges, mental health, substance abuse. That's just not generally where it happens. So, we spend an average of an hour with every patient we see in the home. We'll do that. We'll be invited into the homes of well over 1 million patients this year and see many hundreds of thousands virtually through our telehealth work. And those are extended encounters. And oftentimes the disclosures don't come until the one more thing, doctor moment towards the end of the encounter, if you will. And so it takes some time. And with the senior population in particular, there's so much focus in business in speed and scale and efficiency. But when your product is the encounter and you're talking about the senior population, you got to go slow. You have to talk slow. You have to be, not because the seniors are slow, but because the depth and the richness of the information, the insight and the wisdom you're trying to get from them takes time to disclose, and it takes time to build trust. And so it's foundational that you have encounters that are humanely designed around that particularity. And then from there, that you've got the right intervention engines, if you will, to get that, get the members into care. One final point there, we found in the early goings when we pulled back our house call programs in April, as we were seeing the spread of COVID uncontrolled in so many communities, we pivoted very quickly and amped up our telehealth efforts. And we have seen our rates of video adoption in our telehealth business triple, if not increase 4 times over during the 2.5 months that we started ramping that. And I don't know if that was grandkids teaching grandma how to use Zoom or what, but I think one of the most telehealth has been big all over, the news and is the darling of the investor community now for good reason. We believe there is no substitute for face-to-face encounter. Telehealth is one of those good tools in the toolkit, but the place maybe where it's will, in my view, have the greatest, most powerful, long-lasting impact is in mental and behavioral health. And we're seeing for technology and other reasons, the barriers drop to seniors getting that care. And it's one of the green shoots, I think, that are coming out of this pandemic era, which we have to note has not ended at all. But it's an incredible way to get access to people and get them access to professionals that can help them. The other thing is, the community work that we're doing. Many of those organizations are highly attentive to those issues. And we've just got to think outside the box in terms of the resources. I'm thinking of like a health plan or an at-risk health system now. The resources that we help these people get into. It's not just about us. There are people doing extraordinary work in communities all around America right now on these issues. And we healthcare people need to tap into their access, their knowledge, their wisdom, their experience, and support them in their missions.
Mark, some of these concepts like self-isolation and loneliness, have certainly come into focus here in 2020. Some of that's involuntary because a member or senior wants to or has to, but in other cases it's voluntary where I might not be comfortable inviting someone into the home. How have you had to change your care delivery methods, whether it be telehealth or any other components in terms of how you go about your work?
Yeah, we certainly struggled, like every provider group, to secure PPE. It was a bit embarrassing as a country, but we were creative, and once we did put that in place with even more strict infection control protocols, we were really down for about a week. And our model is a very high touch, high intervention model, really, that we certainly can augment it with telemedicine, but you can't put a gastrostomy tube in with telemedicine. And so we were really back to doing what we were always doing within about a month. And, you know, we work across all populations, Medicare, commercial, and Medicaid. But we're really at our best when we're working with high medical needs and high social needs patients, really the exact population that should have avoided exposure to COVID. So as a result, all of our models really have been leveraged very heavily by folks who, who couldn't get their patients into the hospital. So our ER at home model, home hospitalization took off, recovery at home took off. And, COVID didn't really fundamentally change our model, but it did bring a welcomed awareness and understanding of what we do. We've experienced the delivery of just about everything you can think of to your doorstep during the pandemic. So why not high acuity medical care? In addition, we deployed another model that we kind of created on the fly. Some of our partners asked for it, that we called Clinic Without Walls. And we have a workforce that is everything from physicians to paramedics. And what it does is it sends one of our medics into the home, a single practitioner, and normally our models are 2 people in the home, with a telepresentation device and many of the ancillary capabilities that we bring, like EKGs and labs. And then those medics would then telepresent back to our partnered providers. And this was not designed for, a simple video visit. This was a service designed for patients who would not typically do well with a video visit, like a memory impaired patient, for example, or patients who are more medically complex, where you really need those ancillary services. The complex congestive heart failure patient, where you need an EKG, some blood work, and an echo, frankly, to keep those patients safe and healthy at home without bringing them into the office and risking exposure.
Jason, as we think about our most vulnerable in this type of pandemic, it's not only the elderly, but in many cases those with underlying conditions. Given the critical role that medication adherence plays, really in both of those at-risk populations, where do you see your solutions having the greatest impact in this kind of environment?
Yeah, I did a blog back in, I think it was April, in the healthcare blog, and described how we believe that one of the areas of solution for this pandemic is to focus on medication adherence to protect these vulnerable people. And studies have come out in the last couple of weeks from CDC that show that 94% of the people who have passed away due to COVID actually passed away due to underlying conditions. And where are these people located? They're from the same disparity of care zip codes that existed before COVID occurred, and they're going to be in the same zip codes well after we get a vaccine. And so it really gets down to the brass tacks of how are we going to get to these consumers who have the most needs. I had a conversation with a Medicaid medical director, which I won't say who it is, and you'll understand why, several months ago. And I said, how are you going to get a consumer that can't walk to their mailbox? So age-blind disabled patients are about 25% of a Medicaid population. So how will the age-blind disabled person who doesn't have a caregiver anymore able to get their medications from the local Walgreens or the CVS? How is that person who also can't get to the mailbox, how are they going to get their medications? And what kinds of programs do you have in place for that? The answer was, we have a rideshare program. In the middle of the pandemic, we have a rideshare program so that we can get these people into a small car to go to the local pharmacy. So we need different kinds of solutions. So Adhere Health has a pharmacy for these, I'd say the top 2-3% of these patients, for example, whether it be behavioral health issues or those who need or most need, where we private courier drugs every month for free to the consumer And every single month, we're actually having a conversation with them and often their doctors to change the medications to fit for them. And then we private courier to the person's doorstep on a schedule, not to the mailbox, and hopefully it gets there when FedEx gets there, to their door with purple gloves to help that. But those are the types of things that we have. Our partnership with Amazon Pharmacy, with PillPack, also allows for the same type of thing as well. Sorry, my lights. And depending upon the consumer, when we're engaged with them for this specific issue, what's the best way to engage? It might be a mail order because that works for them. So I personally have asthma, and mail order is great for me. But PillPack might be great for someone who needs compliance packaging and forgets to take their meds, and they take several meds throughout the course of the day. And we can enroll them right into our platform and automatically have that API into the pharmacy OS system for PillPack. But then we also have these patients like at TRX who are really, really sick, are taking 6, 10, 15, 20 drugs a day, and their drugs keep changing every month. And those are the people that really are being impacted mostly with COVID. And as Winston Churchill said many decades ago, never let a crisis go to waste. And this is a terrible, terrible pandemic, but this is something we should be focusing on right now. And we believe, at least with Adhere Health, and I would share this with both Nathan and Mark, is that we need to be part of the solution. And we believe that medication adherence is definitely a part of the solution.
That's great. And a great segue into our final lightning round here, as we're almost out of time. And so I want to give each, an opportunity to spend, 30 seconds and just, give your view on, looking out over the next 10 years, what does community-based care look like over the course of that time? And really, what are the most significant advancements you see unfolding here in the next decade? Nathan, you want to go first?
Sure. I'm going to pick up on Jason's theme and quote Churchill again by saying Americans will always do the right thing after they've exhausted every other option. And I think what this has done for me and my Signify colleagues, I think, is made clear just how tattered this social safety net is at a time when we are realizing its importance to driving the health outcomes that we've all spent our careers in pursuing. And so I think the connection between the clinical and the social, and to the commenter's point, the behavioral, this converging of these strategies and realizing that if you're focused on an outcome, you can't disentangle them is really important. And so what that means practically is that the holders of the risk capital, the payers, the at-risk health systems, have to reach thoughtfully into that social sphere and support these public agencies and private organizations that do this work and meet them on their own terms. And connect them into the health system in careful and thoughtful ways. There's a lot of movement now to get doctors to get engaged in social determinants of health. I'm not convinced that they're the right people to do it, just as I'm not convinced they're the right folks to counsel deeply on advanced directives, and that's not knocking doctors. They're trained differently. And so we have to acknowledge the domain expertise in that space and then use our access to capital, technology, and sophisticated tools to enhance what they do.
Mark, any final thoughts?
This probably won't be surprising, but we believe that care will start and in many cases end in the home. For many patient populations and many conditions, home is the most efficacious site of care. Technology will increasingly be used to enable remote on-demand medical assessments. We'll have longitudinal medical management supported by remote analytics, informed with an understanding of social dynamics. You'll have high acuity in-home medical treatments and in-home end-of-life care. 10 years from now, our hospitals will be used really for what they were intended, surgeries and ICU care for our most sick patients.
Jason, what are the most significant advancements from your perspective?
Well, if you remember back in the 90s, the nation's first healthcare IT czar, Dr. David Brailer, in the Bush administration, put in place health information exchanges. And I think that was a grand idea, but we really haven't proven anything with those RIOs or HIEs. So I believe that the technology has caught up to healthcare, and really it's not about having a lot of data. We have over 30 million consumers in our data platform today we touch every year. It's about actually taking that data and in real time using it to have actions. And so I think over the coming years, you'll see other companies, certainly Pure Health is very focused on this and being an aggregator of all this different disparate types of data, including all the EKGs and all the Bluetooth enabled devices as well. But really using that and actually having actions so a clinician can make a response for that specific issue. And I think we'll see more of that, maximize that engagement, improve customer experience, like companies like Apple have done. Those are the types of things that I think we'll continue to see, and it really is well-deserved. It's all about the data and the clinical workflow.
Great. Well, we're now over our time. I want to, again, thank all of you for joining us here today. There's certainly more than enough to talk about, and appreciate you taking the time. This was fun. So with that, I will pass it back to Michael Carroll for final thoughts and wrap up.
Thanks, Dave. That concludes today's Market Insights Live session. Thanks to all of our panelists for participating, and thanks to everybody for listening in. Our next session is actually 2 weeks from today on Election Day, where we'll continue the conversation on the shift to healthcare at home. We'll do a focus on additional capabilities and really kind of talk about that continuum of care, including end of life. For additional information about all of our Market Insights Live series, you can visit triple-tree.com/Market Insights Live. We have posted all of the replays from prior sessions, as well as information about the upcoming sessions. So again, a big thank you to everybody for participating, and we will hear from you and see the group in 2 weeks. Have a good rest of the day. Thank you.